Hello and welcome to this presentation. I'm very happy to be here and I'm happy that you are where you are. This presentation will be about using AI in a clinical setting for breast cancer screening. My name is Fredrik Strand. I'm a radiologist at the breast imaging department at the Karolinska University Hospital and a researcher at the Karolinska Institute. Okay, let's get started with the presentation. This is the title of the presentation. So, going from retrospective to prospective studies of AI in breast cancer screening. These are my disclosures. I have research funds from the Stockholm Region Authority, also research funds from the Swedish Breast Cancer Association, and I have personal fees for presentation from Lunit Inc. and also cost reimbursement to the study hospital for one of the clinical studies. Let's take a global view. This is the incidence globally of breast cancer, and we can see that many of the high-income countries are represented with a pretty high incidence of breast cancer. When we, after that, look at the breast cancer survival, we can actually see that the breast cancer survival is quite good. It's quite high, the survival in the high-income countries, but is very poor in certain areas of the world where the income level is lower. However, there is another factor that is very important for breast cancer survival, and that is the availability of mammography. As you can see, many of these countries that have a very high breast cancer survival, they have also got a very high availability of mammography. Screening mammography is definitely one of the greatest interventions to reduce mortality in modern medicine. The risk of dying within 10 years of diagnosis has been shown to be up to 41% lower for women participating compared to women not participating in mammography screening. And this has to do with detecting the cancer early, while it's still curable, while it has not spread in any significant amount outside of the breast. At mammography, we take two images of each breast. One is called craniocaudal. It's from the upper side to the lower side of the breast. And the other one is called mediolateral oblique. And it's kind of a tilted sideways view of the breast. So two images of each breast, and they are projection images, meaning that they're kind of a shadow of the tissue that is contained in the breast. So if you have this kind of bright tissue here, it could hide a tumor that is also bright, potentially. So a tumor is bright, this kind of tissue is bright, but the fat is dark. So the more fat, the easier it is to detect the cancer in the breast. This is the process that we have in screening mammography. So each mammogram is read by two radiologists. And I should say that this process is what we have in Sweden and in many parts of Europe, while other settings, I think the US, for example, might have a single reader. But in Sweden, we have two readers, two radiologists reviewing each mammogram. And for about 90% or more than 90% of the exams, they actually agree that the mammogram is normal, the woman is healthy, she will get a letter saying that she's healthy. But for some exams, they flag them for discussion. And if any one of these two radiologists flag it for discussion, two radiologists discuss orally to agree whether to recall the woman or not. And in the end, we recall about 2 to 3% of the women that comes to screening mammography. And in the end of those, we find about 0.5% cancer. So 1 in 200 women that go to screening actually end up with a breast cancer diagnosis, early detection. Double reading is good. It is important to do double reading. Here is an example of if you have one reader and two readers. So they agree to a large extent, but there are some cases detected only by reader 1, and there are some cases detected only by reader 2. So when you combine the sensitivities and the sensitivity, that is how many percent of the cancers that are there are actually detected or seen on the mammogram. So reader 1 in this material, this data that we have looked at, had a 77% sensitivity, reader 2, 81%, but together The joint cases that they detected was 86.6%, much higher. Nevertheless, even though the sensitivity is pretty good, there is a large potential to improve early detection. And that is shown by interval cancers being 30% of the cancers detected in screened women. So a woman that goes to screening have a 30% risk that her cancer will not be detected at screening and a 70% chance that it will be detected on screening. And we would like to improve this to increase the percentage detected at screening early. Even for cancers that are detected on screening, there is 15% of those cancers that are larger than 2 centimeters when they are detected on screening. And that could probably have been detected before, maybe 2 years before, maybe 1 year before, maybe using MRI instead of mammography, but many of those could have been detected earlier. So there is a large potential here shown to detect earlier than we do today. Why is it so difficult to find a cancer? Well, cancers have very varying appearances. These are 4 kind of types of appearances: calcifications, these bright little dots; architectural distortions, the very tricky ones. They kind of pull in the tissue, making the tissue look not as harmonious as it usually is. And these indistinct masses that has like a tumor body that you can distinguish in the image. And they have the spiculated masses, the classic appearance of cancer, where you have spiculations going out from this central mass. But it's not only the cancers that vary much in appearance, but it's a projection image. So all the benign tissue becomes superimposed on top of any possible tumor. So that is also something you need to see through, distinguish between the benign tissue, the cancer tissue, and sometimes it's not possible because the normal tissue is so dense that the cancer just doesn't show up in the mammogram. So it's a very tricky business. You need very highly skilled breast radiologists and very good equipment. Of course, it's been tried for a long time to use computer programs to help in this screening where 99.5% of women are actually healthy, but we need to review the mammograms carefully anyway. And of course, computer programs have been developed, but traditional approaches to machine learning, traditional approaches to CAD has not been so successful. They have been, in some studies, able to increase the sensitivity a little bit, but far from the increase by double reading. And also they have caused a lot of false prompts. Many circles, many areas suspicious on the mammogram that the radiologists then have to consider, and it takes a lot of time. So this never became very popular here in Sweden and most parts of Europe, but I think it was it was quite well used in the US, as I understand it. However, now we have come into the era of artificial intelligence based on deep learning, deep networks, deep neural networks. And this has great potential. Before our study, before our retrospective comparison study, there were single studies of single algorithms out there in very high impact journals. So there was in JNCI, in Nature, and in Lancet Digital Health, it was shown that AI could actually perform on a level similar to radiologists. The thing is that when you want to compare algorithms, you want to see, are they similar? Are one algorithm much better, much worse? How do they compare to radiologists? You need to compare them in a similar setting. They need to run the same track. So that's why we started our comparison study, where we used a very large retrospective data set with 739 cases of breast cancer, and we compared 3 different commercial algorithms with each other and with radiologists. And what we found was that the best AI algorithm of the 3 had an 81.9% sensitivity. So it detected 81.9% of the cancers that would arise or be diagnosed within 12 months of the exam. If you compare that to the other 2 AIs, it's much higher. And if you compare it to the radiologist, it's actually higher than radiologist 1, statistically significantly higher. but it's on the same level as reader 2, the second radiologist. So very good performance, and not AI are the same. So how could we use the AI? We could use it as an assistant. It could inform a single radiologist in a single reader setting. It could perform independent assessments in a double reading setting. And it could actually also, in some cases, be the only reader for very easy to read mammograms where the probability of cancer is very low. It can be so that AI can assess them on its own without any human intervention. And on top of this, AI could possibly be used also to select which women would benefit the most from supplemental screening, like adding another method on top of mammography that is more sensitive, like MRI or contrast mammography. And when you want to combine AI in a double reading setting, if you combine two readers, as we saw before, the sensitivity increases a lot. So the combined reader 1 and reader 2, they had a sensitivity of 86.6%. But that's not the only important measure. Of course, specificity is important. We don't want to worry healthy women unnecessarily. And specificity 95.7% means that 95.7% of the healthy women are left alone. They don't have to be discussed. They don't have to be recalled. However, if you combine reader 1 with AI 1, the best AI, the sensitivity is at least as high, maybe slightly higher than combining two radiologists. But the specificity suffers. So the specificity goes down. And this is because AI and humans make different false positive mistakes. Two human radiologists makes more of the same false positive mistakes, so the specificity remains rather high, even if the sensitivity is increasing. But when combining a radiologist and AI1, you have to accept at the moment that you get an increase in the total number of false positive exams. So the number of cases that needs to go to consensus discussion would increase significantly by more than 50, maybe 70% compared to today. But of course, you would save resources because you don't have to, you can only have one radiologist reading all the screening mammograms and one AI. In our comparison study, it was very interesting to see that the number one algorithm, and that was the algorithm from Lunit, South Korea, it had been trained mainly on Korean women. And we don't have that many Korean women in Sweden, so the populations are quite different. And nevertheless, it performed the best. And it was trained on a majority of equipment from GE, while we have Hologic only in our screening department. So it was interesting to see that even if the distribution of equipment and ethnicity was different between the development population and our test, it was still had a very good performance. When assessing these kinds of retrospective studies, it's important to remember that there are different conditions for human and radiologists in these retrospective studies. For example, the human radiologist compares with mammograms from the prior screening, and that's not something that AI currently is doing. Also, the human radiologist receives information about patient symptoms. For example, the patient might have felt a lump in the breast last week, and then we need to recall that woman. And if that is not cancer, it will create a lower specificity. But of course, if it is cancer, it will contribute to the radiologist detection. Radiologists are also informed by prior diagnostic workup of non-specific lesions. So we could find out what was the fine needle aspiration result, what was the biopsy result from the electronic health records. But also, the human radiologist could suffer from some performance variations due to alertness, mood, and recent experiences. These are just some examples. I will show you some cases now in the retrospective studies where these cases were detected by the AI1 and missed by the radiologist. So this one here was detected by AI1 but missed by the radiologist one, is this area here. This is another case that was detected by AI1 but missed by the radiologist. This was found to be cancer. These are now some cases that are the other way around. So they were detected by the radiologist, but missed by AI1. This little thing here was missed by the AI1, but detected by the radiologist. It got an abnormality score from the AI that was not super low, but it did not reach the threshold for malignancy. Another thing here, a very subtle area that was missed by AI1, but was suspicious for the radiologist. Okay, so in addition to this comparison study, we made another study only using the AI1, the Lunit CAD system, Insight MMG, where we used it to study previous screening mammograms for women that were later detected to have either interval cancer or next round screen detected cancer. And when we looked at if the AI could triage some of the mammograms as healthy without the need for any radiologist to review them, we found that up to 60% of the lowest AI scores, there would be no missed screen detected cancer. However, there were interval cancers, but there were no missed screen detected cancer up until the 60% level. And when we looked at if AI could predict an interval cancer or a next round screen detected cancer, that is not no cancer in this round, but in the next round, it was also pretty good. So within the 5% highest AI scores, we found the 27% of the interval cancers and 35% of the next round screen detected cancers. And that's a very high PPV, like 34 in 1,000. So if we would do the perfect radiological examination of these women, and also assuming that there is a cancer already now visible, if you use the perfect method, we would find 34 additional cancers in 1,000 women examined. So a very interesting avenue for AI. So let's move on to the prospective clinical studies. We have shown, others have shown in retrospective studies that AI seem to be quite good at the moment, reached a level that is at or slightly above some radiologists. Let's move to prospective clinical studies where we attempt to try out how AI actually works in a real clinical setting. We do this in collaboration here in Stockholm, Sweden, between the Karolinska Institute, the Karolinska University Hospital, and the Royal Institute of Technology, KTH, abbreviated in Swedish, and SciLife Lab. We also have a commercial partner then contributing the CAD system. So these prospective studies, there are two of them, are starting now in March 2021, actually starting next week. So one is called ScreenTrust CAD, AI as an independent reader of screening mammograms. And the other one is called ScreenTrust MRI, Finding Masked Cancer by AI Selection for MRI. I will tell you a bit more about those. The first one, ScreenTrust MRI, Finding Undetected Cancer by AI and MRI. This is the illustration of the study. So we have normal screening mammograms. They have already been assessed, double read by radiologists. The woman knows she's healthy from a mammography perspective. We apply a pipeline of AI models, and women that meet certain criteria will be eligible for invitation for MRI. And on MRI, we hope to find undetected cancer. The background for this study is that we know that the risk of death increases by the stage of diagnosis. So, for example, one important prognostic factor is lymph nodes. If you have no lymph node metastasis, the risk of death is much lower than if you have 1 to 3 lymph nodes or 4 to 9 lymph nodes with metastasis. Also, the treatment cost increases by stage of diagnosis. These are US figures from 2010, so they're old, but nevertheless, you can see that from stage 0, $60,000 cost to the society and personal cost, it increases, at least doubles if you go up until for example, stage 3 here. And one study that was an inspiration for us was the DENSE trial by Carla Van Gils as the PI, which showed that MRI can reduce interval cancer with more than 80%. In this study, they invited women only based on having extremely dense breast tissue, and that's about 10% of the women with the most dense tissue. And here you see the different tissue density categories. The least dense, 10%. Then you have BI-RADS B, scattered density, and BI-RADS C, heterogeneously dense tissue, and the BI-RADS D, extremely dense. And these were the ones that were included in the DENSE trial. And they found that the interval cancer rate was 5 per 1,000 for women that did not have the MRI, and 0.8 per 1,000 for the women that actually did MRI, which was 59% of the ones that were invited. In our study, we will use 3 different AI models. Cancer detection. Is there some kind of subtle cancer sign visible in the mammogram? Even signs that are not enough to recall a woman could be important from a prediction perspective. How about the mammographic masking? Could a cancer be obscured by normal tissue in this mammogram so that there is not really any cancer visible, but the normal tissue makes it very hard to see cancer if it would be there? So does it have a high potential for this kind of mammographic masking? That's the second model. And then the third model is a kind of risk prediction model, a short-term risk prediction model, which is based on risk patterns in the parenchyma of the breast as shown on the mammogram. I will go through these one by one. They work together. So for cancer science, we have already seen that AI can be very good. The best AI in our study found a lot more cancer than the other 2. We have also developed our own AI cancer detector here in Stockholm in this collaboration, in the academic collaboration that will be used in the study. It will be used together with the commercial one. For the masking estimator, we have developed that ourselves in this collaboration between the engineering and clinical research. So 5 radiologists were shown a total of 12,500 mammograms, and they were shown 2 and 2. And the radiologist's task was to decide, would a cancer be harder to see in the mammogram on the left or on the right? And after thousands of such forced choices, we then trained an AI algorithm to mimic this decision-making process of the radiologist. So the AI, the masking estimator, the purpose of that, the output of that algorithm is to say, how difficult would it be to see a tumor in this mammogram if there was actually a tumor in the breast? When it comes to short-term risk prediction, we have published that before. We have trained the model based on healthy mammograms for women that later got diagnosed with breast cancer compared to healthy mammograms for women that remained healthy. And we have shown that using AI, you can reach a higher accuracy than using only the traditional measure of mammographic density. So the normal screening mammogram will be fed to this AI pipeline, which will then consider risk patterns. It will look at the masking potential, and it will look at any subtle cancer signs that are there. And the women with the 8% highest scores, they will then be randomized to have an MRI or not have an MRI. And in the end, what we will see is that after the screening mammography and after the screening MRI for the ones that are randomized to that, how many will still be detected with a late, significantly delayed cancer detection. We'll compare that between these 2 groups, the women that had MRI in screening and the women that did not. And what we will look at as the primary endpoint is the sum of interval cancer, invasive cancer larger than 15 millimeters, and lymph node positive cancer, because we think that these conditions mean that the cancer was clinically significantly delayed. So we'll compare the difference in significantly delayed cancer diagnosis between the women having and not having the MRI. We will have a follow-up period of 27 months, and we will perform, our goal is to perform 1,000 MRI exams. Now, let's turn to the second clinical study. This is a study of AI as an independent reader of screening mammograms. It will be performed at the Capio St. Göran Hospital here in Stockholm. The study population is 55,000 women, and all their screening mammograms will be assessed by radiologist 1 and radiologist 2 as usual, and by the Lunit CAD system. And if any of the three thinks that there is something suspicious in the image, it will go to an oral consensus discussion held between radiologists. And they will have access to the CAD information in this consensus discussion. In the end, we will see if having two radiologists compared to radiologist 1 and AI, if it's a non-inferiority study, so you want to see if radiologist plus AI is non-inferior to 2 radiologists. It's a very interesting study. And these are early examples from the study. So here we can see that this was actually thought to be healthy by the second reader, but the AI said it's positive. The CAD score is just above the threshold, and this area is suspicious. We don't know how this will turn out because we have just got this in yesterday. This is another area found to be positive by AI, and it looks suspicious now when it's highlighted by AI, and we will see how that one will turn out as well. This one, however, is healthy from a radiologist perspective, and it's also healthy from an AI perspective. The AI assessment is negative here. So these are just some very early images from the interesting Screen Trust CAD trial. In summary, so retrospective studies have shown that AI can be at least as good as a radiologist in detecting cancer. However, prospective studies are needed, and they are underway to show how this turns out in a real clinical setting, to improve the efficiency by replacing one radiologist in a double reading setting, and to improve early detection by inviting women for MRI. Thank you for listening, and I hope you have enjoyed the presentation. These are a list of my collaborators and funders to the right. Thank you.